Dear viewers, this video is number 10 in the series on cancer, that is neoplasia, in the Medicine for Common Man series. So, coming back to the discussion, Epstein-Barr virus. EBV or Epstein-Barr virus is a member of the herpes virus family, was the first virus linked to a human tumor, Burkitt lymphoma. EBV has also been implicated in the pathogenesis of a diverse collection of human tumors, including various lymphomas, several carcinomas, and even rare sarcomas. The most common EBV associated tumors are lymphomas derived from B cells and nasopharyngeal carcinoma. EBV has surface glycoproteins that recognize and bind the complement receptor CD21, allowing the virus to attach to and infect B cells. This probably occurs in the tonsils following exposure to the virus in saliva. Viral infection of B cells is latent. There is no viral replication and the cells are not killed. However, EBV proteins are expressed in latently infected B cells that allow the cells to grow indefinitely, that is, immortalization. The molecular basis of B cell growth and immortalization is complex, but as with other viruses, it involves the hijacking of several normal signaling pathways. Thus, the virus borrows normal B cell activation pathways to expand the pool of latently infected cells. The EBV proteins that are required for B cell immortalization and proliferation are highly immunogenic, and in normal individuals, the EBV driven polyclonal B cell proliferation is readily controlled by a cytotoxic T cell response. Depending on the timing and intensity of this response, the individual either remains asymptomatic or develops a self-limited episode of infectious mononucleosis. If T cell immunity is defective, however, EBV transformed B cells can produce a rapidly progressive fatal lymphoma. In summary, in the case of Burkitt lymphoma, it seems that EBV is not directly oncogenic, but by acting as a polyclonal B cell mitogen, sets the stage for the acquisition of the 814 translocation and other mutations that ultimately produce a full-blown cancer. In most individuals, EBV infection is readily controlled by effective immune response, and lymphomagenesis is rare. By contrast, in regions where Burkitt lymphoma is endemic, cofactors such as chronic malaria may favor the acquisition of additional genetic events, example, translocation of between 8 and 14 chromosomes that lead to transformation. So, dear viewers, by the way, this educational video is made possible by Prescribon, the makers of e-prescription software for digital prescriptions available freely for doctors on the website www.prescribon.com. Doctors who are interested in this e-prescription can freely avail of its vast collection of more than 100,000 e-prescriptions. Nasopharyngeal carcinoma also is strongly associated with EBV. This tumor is endemic in southern China and parts of Africa. All nasopharyngeal carcinomas contain EBV. The structure of the viral genome is identical, that is clonal, within individual tumors, indicating the EBV infection has occurred before tumor development. EBV thus has a central role in the genesis of nasopharyngeal carcinoma, but as with Burkitt lymphoma, its restricted geographic distribution indicates that genetic or environmental cofactors also contribute to its development. Hepatitis B and C viruses. Worldwide, 70 to 80%, 85% of hepatocellular carcinomas are associated with infection with hepatitis B or C viruses. Hepatitis B virus is endemic in countries of the Far East and Africa. Correspondingly, these areas have the highest incidence of hepatocellular carcinoma. Despite compelling evidence incriminating HPV and HCV, the mode of action of these viruses in liver tumorigenesis is not fully elucidated. Oncogenes have yet to be identified in HBV or HCV genomes. Although the HPV DNA is integrated within the human genome, there is no consistent pattern of integration in liver cells. Indeed, while the oncogenic effects of HBV and HCV are multifactorial, the dominant effect seems to be immunologically mediated chronic inflammation and hepatocyte death, leading to hepatocyte proliferation during regeneration and over time genomic damage. As with any cause of hepatocellular injury, chronic viral infection leads to the compensatory proliferation of hepatocytes. This regenerative process is aided and abetted by a plethora of growth factors, cytokines, chemokines, and other bioactive substances. These are produced by activated immune cells and promote cell survival, tissue remodeling, and angiogenesis. The activated immune cells also produce other mediators such as reactive oxygen species that are genotoxic and mutagenic. One key molecular step may be activation of the NF-kB pathway, which blocks apoptosis, allowing the dividing hepatocytes to incur genotoxic stress and to accumulate mutations. Note: nuclear factor kappa B, NF-kB. Nuclear factor kappa B is an ancient protein transcription factor. It's a regulator of innate immunity. The NF-kB signaling pathway organizes cellular resistance to invading pathogens. HBV genome also contains genes that may directly promote the development of cancer. In addition, viral integration can cause structural changes in chromosomes that dysregulate oncogenes and tumor suppressor genes. Although not a DNA virus, HCV is also strongly linked to the pathogenesis of liver cancer. The molecular mechanisms used by HCV are less well defined than are those of HBV. In addition to chronic liver cell injury and compensatory regeneration, components of the HCV genome, such as the HCV core protein, may have a direct effect on tumorigenesis, possibly by activating a variety of growth promoting signal transduction pathways. Viral and bacterial oncogenesis. Overview: HTLV1 is a retrovirus that is endemic in Japan, the Caribbean, and parts of South America and Africa that causes adult T cell leukemia cum lymphoma. HTLV1 encodes two viral proteins, TAX and HBX, which are suspected to contribute to leukemogenesis through uncertain mechanisms. After a long latent period, decades, a small fraction of HTLV1 infected individuals develop adult T cell leukemia lymphoma, a CD4 positive tumor that arises from an HTLV1 infected cell, presumably due to acquisition of additional mutations in the host cell genome. Human papillomavirus (HPV). It is an important cause of benign warts, cervical cancer, and oropharyngeal cancer. Oncogenic types HPV encode the viral oncoproteins E6 and E7, which bind to P53 and RB respectively, with high affinity and neutralize their function. Development of cancer is associated with integration of HPV into the host genome and additional mutations needed for acquisition of cancer hallmarks. HPV cancers can be prevented by vaccination against high-risk HPV types. EBV, ubiquitous herpes virus, implicated in the pathogenesis of Burkitt lymphoma, B-cell lymphomas in patients with T-cell immunosuppression, that is HIV infection, transplant recipients, and several other cancers. The EBV genome harbors several genes encoding proteins that trigger B-cell signaling pathways. In concert, these signals are potent inducers of B-cell growth and transformation. In the absence of T-cell immunity, EBV-infected B cells can rapidly grow out as aggressive B-cell tumors. In the presence of normal T-cell immunity, a small fraction of infected patients develop EBV-positive B-cell tumors, that is Burkitt lymphoma, Hodgkin lymphoma, or carcinomas. Example, nasopharyngeal carcinomas. HBV and HCV cause 70 to 85% of hepatocellular carcinomas worldwide. Oncogenic effects are multifactorial. Dominant effect seems to be immunologically mediated chronic inflammation, hepatocellular injury, and reparative hepatocyte proliferation. HBX protein of HBV and the HCV core protein can activate signal transduction pathways that also may contribute to carcinogenesis. H. pylori. It is implicated in gastric adenocarcinoma. Pathogenesis of H. pylori induced gastric cancers is multifactorial, including chronic inflammation and reparative gastric cell proliferation. Chronic H. pylori infection leads to polyclonal B-cell proliferations that may give rise to a B-cell lymphoma of the stomach as a result of accumulation of mutations. Clinical aspects of neoplasia. Clinical manifestations. Ultimately, the importance of neoplasms lie in their effects on patients. Although malignant tumors are of course more threatening than benign tumors, any tumor, even a benign one, may cause morbidity and mortality. Local and hormonal effects. Location is a critical determinant of the clinical effects of benign and malignant tumors. Tumors may impinge upon vital tissues and impair their function, cause death of involved tissues, and provide a nidus for infection. A small 1 cm pituitary adenoma, although benign and possibly non-functional, can compress and destroy the surrounding normal gland and thus lead to serious hypopituitarism. Note: pituitary gland, which is also known as hypophysis, is a small pea-sized gland located at the base of your brain below the hypothalamus. It sits in its own little chamber under the brain known as the sella turcica. It's a part of the endocrine system and is in charge of making several essential hormones. Cancers arising within or metastatic to an endocrine gland may cause an endocrine insufficiency by destroying the gland. Neoplasms in the gut, both benign and malignant, may cause obstruction as they enlarge. Benign and malignant neoplasms arising in endocrine glands can cause clinical problems by producing hormones. Such functional activity is more typical of benign than of malignant tumors, which are more likely to be poorly differentiated and non-functional. In addition, non-endocrine tumors may elaborate hormones or hormone-like products and give rise to paraneoplastic syndromes. The erosive and destructive growth of cancers or the expansile pressure of a benign tumor on any natural surface, such as the skin or mucosa of the gut, may cause ulcerations, secondary infections, and bleeding. Melena, that is blood in the stool, and hematuria, for example, are characteristic of neoplasms of the gut and urinary tract, respectively. Cancer cachexia. Cancer cachexia is a hypercatabolic state defined by a loss of muscle mass with or without loss of fat that cannot be explained by diminished food intake. It occurs in about 50% of cancer patients, most commonly in individuals with advanced gastrointestinal, pancreatic, and lung cancers, and is responsible for about 30% of cancer deaths. It is a highly debilitating condition characterized by extreme weight loss, fatigue, muscle atrophy, anemia, anorexia, and edema. Mortality is generally the consequence of atrophy of the diaphragm and other respiratory muscles. The precise causes of cancer cachexia are not known, but inflammatory mediators, particularly TNF, IL-1, and IL-6, appear to have important roles. Note: IL-1 and IL-6. IL-1 is a leukocyte pyrogen, a mediator of fever, and a leukocytic mediator, and an inducer of inflammatory response, and lymphocyte activating factor, LAF. Interleukin 6, IL-6, produced in response to infections and tissue injuries. It contributes to host defense through the stimulation of acute phase responses, hematopoiesis, that is blood production, and immune reactions. Paraneoplastic syndromes. Some cancer-bearing individuals develop signs and symptoms that cannot readily be explained by the anatomic distribution of the tumor or by the elaboration of hormones indigenous to the tissue from which the tumor arose. These are known as paraneoplastic syndromes. These occur in about 10% of persons with cancer. Paraneoplastic syndromes are important to recognize for several reasons. They may be the earliest manifestation of an occult neoplasm. In affected patients, they can cause significant clinical problems and may even be lethal. They may mimic metastatic disease and therefore confound treatment. A few comments on some of the more common and interesting syndromes follow. Endocrinopathies are frequently encountered in paraneoplastic syndromes. By definition, the responsible cancers are not of endocrine origin, and the secretory activity of such tumors is referred to as ectopic hormone production. Cushing syndrome is the most common endocrinopathy. Approximately 50% of affected individuals have carcinoma of the lung, chiefly the small cell type. It is caused by excessive production of corticotropin, that is adrenocorticotropic hormone, ACTH. Acanthosis nigricans is a disorder characterized by gray-black patches of thickened hyperkeratotic skin with a velvety appearance. It occurs rarely as a genetically determined disease in juveniles or adults. In about 50% of the cases, particularly in adults older than age 40, the appearance of such lesions is associated with cancer, most commonly carcinoma of the stomach. Clinical aspects of tumors overview. Cachexia. It is a progressive loss of body fat and lean body mass, accompanied by profound weakness, anorexia, and anemia, that is caused by release of factors by the tumor or host immune cells. Paraneoplastic syndromes. Symptoms complexes in individuals with cancer that cannot be explained by tumor spread or release of hormones that are indigenous to the tumor cell of origin. For example, endocrinopathies like Cushing syndrome and hypercalcemia, neuropathic syndromes like polymyopathy, peripheral neuropathies, encephalopathy, and myasthenic syndromes. Skin disorders like acanthosis nigricans and hypercoagulability. Dear viewers, and this is the concluding series, that is the 10th part of the series on cancer, that is neoplasia, in the Medicine for Common Man series. Thank you for watching the video.